And we are back. I want to once again thank our panelists from our opening session today. Just a fantastic way to kick off the patient engagement virtual day today. If you are just joining our June Digital Health Virtual Program for the first time today, all of our sessions will be available on demand by the end of the day today. And as another reminder, all of today's sessions have been created to be interactive. Our faculty is ready and waiting for your questions, so please do not be shy. To submit a question, simply utilize the chat function within the Zoom platform. It is now time for our next session of the day, which will be a fireside chat on delivering better patient experiences with an always-on approach. So I would like to, at this time, welcome on to the virtual stage, Ambika Agarwal from SurveyMonkey to kick off our next session. Ambika.
Great, thanks so much, Matt. Hi, everyone. I'm Ambika Agarwal, and I lead product marketing at Momentive, the parent company of SurveyMonkey, where I focus on bringing healthcare solutions to market. Previously, I held product management roles at healthcare tech companies at both Lyra Health and Athena Health. And I would like to turn it over to my co-host, Lewis Madison, for a quick intro.
Yeah, hi, thank you, Ambika. So for a quick intro on myself, I'm an advisor to SurveyMonkey on healthcare. And my background as an advisor is for the last several years, I've been working very closely with payers, including one of the largest Medicaid plans in the US, along with providers. Some of you may have heard of some like ChenMed. That's in the group of providers I've gotten close to, trying to bring both the payer and the provider perspective. Prior to that, I headed up the Future Ventures program at Anthem, which is one of the largest health plans in the US. And then even before that was a senior advisor in the Office of the National Coordinator to the first national coordinator, so very close to the EMR agenda. The importance of that is health IT and payers and providers, every bit of it is converging together, and none of it exists in a silo anymore. So I'm glad to be here with you all.
Great, thanks, Lewis. So before we get started, I wanted to give you some context as to why we're here. I'm sure many of you are familiar with SurveyMonkey as a tool and product and may have actually used it to collect feedback, but you might not be aware of how we actually fit into the healthcare space, specifically for providers and payers. So over time, we organically became a go-to vendor for healthcare organizations looking to collect feedback on patient and employee satisfaction. And over time have worked to build a platform that healthcare professionals can use to enable better decision-making and delivering superior healthcare outcomes by really leveraging that feedback in meaningful ways. So we're really unique in that we lean on what makes our tool so beloved and so used. We're very agile, we're intuitive, and we're an integrated solution built to really empower organizations with actionable insights across the continuum of care while making sure to maintain compliance with industry standards like HIPAA. So, what we've seen is that our customers use us in a variety of different ways, whether it's patient experience teams, analyzing patient satisfaction trends over time, or HR and medical teams measuring employee engagement and burnout, or training and development or learning and development teams assessing the effectiveness of their training programs and continued medical education programs. There's really a multitude of different use cases that our platform really helps support. It's also worth mentioning that we find that a lot of our healthcare customers use us in addition to tools and vendors like Press Ganey, who are essentially collecting CAHPS and HCAHPS scores. And we work alongside them because we can really help provide that context in real time in a digital way to really help organizations understand the drivers of those HCAHPS and CAHPS scores. So that's a little bit of context about SurveyMonkey, how we fit into the healthcare space. And now I want to really start our fireside chat. So the first question I have for you, Lewis, is let's just talk a little bit about the reality of healthcare today. what are some of the biggest challenges you're seeing that healthcare organizations are facing today in today's reality?
Yeah, so that's that's a big question, especially taking the provider, the payer, and many other perspectives. I think one of the biggest challenges or shifts we see in today is increased competition from new entrants. And so in the past, it might have been viewed as competitive competition between two hospitals or between physician groups or between and among health plans. But now we're seeing very, very large new entrants entering into the space, and everybody's trying to figure it out, whether you're the provider or the health plan. So when we see Walmart and Amazon getting into healthcare, it causes really, really big questions about where do we fit, or where does each of us fit? And then we see CVS acquiring one of the largest health plans in the US, and that starts to really create a tectonic shift. And then another example I'll show is even outside of those large, technology-oriented players, you've got new breeds of physician groups that are entering. And so now a health system that previously may have had patient loyalty might be worrying about the new flashy clinics that are showing up, and patients are saying, I want to go there, or I want to check it out. So what we're really seeing here is a real push patient for the patient loyalty. I think that's probably one of the biggest wild cards that's out there, but one that everybody's facing, if I add another, is there's a rapid shift to digital. It seems like an obvious statement, but it comes on a few fronts. One, we're finally seeing the comeuppance of telehealth. It took us a year of COVID to really get there. But I remember when I was at a very, very large health plan, and I actually brought virtual visits to this plan to make it available for consumers. And there were a lot of questions with the actuaries on how is this going to impact utilization. And it's shocking, it's amazing, it's wonderful to see the shift from how that went 10 years ago to how it is happening today. But as part of that, I think we're going to have to think about how does telehealth and other digital play forward, because now everybody's moving back toward in-person visits. And so we're going to need to find the balance of who wants telehealth and what are they going to want telehealth for. Like when we see boomers, I saw a great survey from HEMS where they showed that 19% of boomers would want a telehealth visit over in person. So 80% still want to go in person when the option is there, but 40+% of it's either millennials, I think it's millennials, they would prefer to be virtual. And so we're going to see a real choice set happening around how people use technology differentially. So I think those are probably two major things to be thinking of. There's a third, which we will get into. I won't go into it too much now, but a third that if the question doesn't come up, I'll find a way to weave it in. And that is, how do we address these initiatives that are happening at scale? So we've got all these things happening, and yet all the clinicians and all of those of us who are trying to do our jobs are just pressed with so many initiatives that must happen. But we're also trying to see patients too.
Yeah, that's great, Lewis. And the last point you mentioned is really critical. And as you said, we'll get into it in more detail, but it's something that we actually see from our customers all the time as a key pain point, especially in the last year. So with all these new initiatives, with the pandemic, with telehealth, with new EMR workflows, there's really that administrative burden that's on providers and staff, which in turn and over time leads to provider burnout. And that's something that we hear time and time again is there's the massive amount of provider burnout and attrition and lack of engagement happening in these healthcare organizations. And I think, what we always say coming from a company that really believes in feedback is the first step in tackling that is understanding how widespread it is and what those drivers are so that you can at least have a baseline understanding. And then you can start to kind of build policies and start to tackle it and take action on it once you actually understand the root cause of the problem. So it's something that we hear all the time, and it's really one of those key use cases, as I talked about before, that tends to be coming up a lot.
Yeah, I would agree with that wholeheartedly. And as we always talk about the consumer, there's this notion, there's also the idea that the providers and lay people who have picked this as their calling, their mission. It's one thing to look at consumer effort, which is the thing that gets in the way of consumers getting the health that they want, health needs that they want met. But it's also, I never hear the expression provider effort, but that's there too. And how do we get those things tempered down or out of the way so that providers can serve the patients that we're trying to create a great experience around? So I agree 100%.
Absolutely. Okay, so let's move on to talking about the patient experience measured by CAHPS and HCAHPS. So CAHPS is one measure that's very important and certainly tied to reimbursement. But just curious on your thoughts on how we really go beyond CAHPS and HCAHPS, especially given that in our digital world, CAHPS is actually not digital. So would love to hear your thoughts on how we go beyond CAHPS and HCAHPS as a measurement of patient satisfaction and experience.
Yeah, it's a great question. And I thought about this morning. It's like I started thinking about the SAT, and all of us who have taken the SAT, and or our kids maybe taking some other standardized tests or whatever. And at the end of the day, the standardized test doesn't tell us how awesome we are as a person or as a kid, but it's a test we have to go through. And then there's the essays that we get to write. Then there's the other things about our lives that get captured, and that really tells the whole story of who we are. And even then, it's hard to be graded. But being graded on SATs alone, LSATs, GREs, or pick another. I forget what I'm trying to think of the one that my daughter took, which she called it the ERG or the MERG or something. The ERP. She tried to create an acronym that sounded like a burp because she hated it so much, and it did not. It was important for measuring, but it didn't tell the full story of who she was. So that's the first casual comment about it. But I also think that as we think about CAHPS, it's important to have it as a standardized test or a standardized set of questions. But beyond that, the more important metrics of success are not how well did you do on CAHPS. That's a byproduct. Ultimately, the real metric of success is going to be, in a world of patient choice, it is patient mind share, or if you're a health plan, it's member mind share, it's member loyalty, it's patient loyalty. And that's ultimately the real measure of success. If you get an awesome CAHPS score, you get a bonus, right, on the patients and members who still want to choose you for all of the things that they can choose you for. But if they're not choosing you for one thing or 10 things or for anything, then a bonus on nothing is meaningless. And so at the end of the day, I like to think about how you win the patient experience game in terms of winning loyalty. And so to get there, you need to think about things that beget trust. Patient trust creates patient loyalty. And then if the member feels like their health needs are met, like they're being healed, like they truly are getting better, or at least are as maintaining as well as they can maintain, then you build a sense of trust that, a few more minutes waiting on a telephone line with a customer service rep, it's okay if they feel like at the end of the day, their needs are going to be met. They won't worry about the effort if it doesn't feel like effort, because the promise of what they're going to get is there. But there are aspects of CAHPS which try to get at that customer service aspects, the little things. But I think it's important to know that we do need to focus on the little things that might shake trust. It could be a parking spot. I've talked to a few hospital administrators, and a lot of them talk about parking. I don't know if this is a common issue that we should we should all focus on, but parking is an example of something that can frustrate someone, and it gets in the way of trust. So we need to know those, but those are not on the CAHPS. They're not on the surveys. We need to understand what are the little things that get in the way of all the great things we're accomplishing as we're interacting with patients. And then by asking those questions and finding a way to act on them in a way that our patients, our members see us trying, it actually brings out the human element. We are humans delivering healthcare and wellness to other humans. And I think that's just a really critical aspect of humanizing it by showing the intentionality of how we care and are trying to act. So that's probably my first overarching comment. So I guess, Mbika, one of the, I guess the question is, so what do you do that goes beyond CAHPS? You know, two things that I've seen, I'll just give you two perspectives. One is I've seen people take a very simplistic approach around NPS, and it's like the Gordian knot. You know, people are trying to figure out the Gordian knot way back when. I think that was Alexander the Great. And the idea is, you know, sometimes you just chop right through something and get to the answer. And the other is going to be how you put a campaign around each individual. But the simple view of the Net Promoter Score is, while I've heard some healthcare organizations are uncomfortable using it because they don't feel like their stakeholders understand it, as well as other metrics that they prefer. So I encourage people, use the metrics that your stakeholders react to. But I know of other groups where NPS matters. And so, for example, there are some healthcare providers who will promote they'll publish their NPS scores as they're talking with health plans and others to show how they stack. And there's a whole new breed of these physician groups that are doing it. It's, you know, within there's Agilon, Oak Street, ChenMed, and their NPS scores are in the 80s and 90s. It's truly this oasis of healthcare where you have these incredibly high NPS scores. And the health plans love it. When they bring one of these partners into a market, they're actually showing that they're offering something where the NPS scores for the people that are being served in totality will rise. And then another thing I'll share on those is there's a CEO of a very large multi-specialty group that plays in this same category. And he has a protocol where if anyone gives them less than an 8 or a 9, I forget which one it was, but it's a high threshold, they get contacted and he finds out why. And what's he getting out of that? Well, A, the people know that he cares, or that the organization cares. But importantly, they're finding out things that don't show up on regular surveys. And by the time the CAHPS survey comes around, they're going to do awesome, but they're also going to win on mind share and loyalty. So I just think NPS is it's not just for other sectors. It can be used very, very effectively in healthcare.
Yeah, I think that, you know, that's so interesting. And what we hear is that the response rates from CAHPS surveys, one is that, you know, they're quite lengthy, right? But they're also very low because they're all conducted via mail and phone. And while that might work for some patients, for some consumers, a lot of consumers prefer to engage via SMS or email, and that's just kind of the norm in how they engage with healthcare. And it's just interesting that CAHPS hasn't kind of taken that step to be digital and actually meet patients where they are and engage with them in the way that they prefer to be engaged with. So I think, you know, that's a common struggle that we hear from organizations is like, yeah, CAHPS is one piece of it, but it doesn't tell the full picture because we're getting really low response rates and we're not actually getting to the patients who prefer to be engaged with through SMS and email and other digital means.
Yeah, it's a real lost opportunity when you don't get feedback that people would want to give if you met them where they wanted to be met.
Right, exactly.
It's like in the Washington Post, and I'm not plugging them. I'm just saying I love the advertisement where it says, if you don't get it, you don't get it. And here's an example. If you're not getting the feedback, then you don't get a chance to really improve.
Yep, absolutely.
Yeah.
All right, so I want to shift gears a little bit and go back to a topic that we started to cover that I think is really important to cover. So as organizations, you know, move towards a value-based care model, we're seeing a lot more research that supports the notion that employee experience and employee engagement has a strong correlation with patient outcomes, not just patient experience, but actual patient outcomes. You know, and I, you know, there's definitely research that supports this, but I'm just wondering, based on what you've seen in working with a number of different organizations. What are your thoughts here? And are organizations kind of rallying behind that notion, or is it still something that's being proven out?
Yeah, I think as we get into value-based care, really enabling the providers and other lay people is going to be, it's critical to the success model. So I've worked with organizations who take full global risk. I've worked with organizations that do value-based agreements at a level below that. I've seen, some that do gain shares and bonuses, but in the whole spectrum of value-based care, there's a new intentionality around understanding the total view of the patient that becomes critical. And as part of that, it means there's going to be there's new initiatives that we have to understand. How are they working? Are they working well with the providers and other lay people in a way that is effective, that doesn't create burnout, that doesn't create any abrasion. I dislike the word abrasion, but I used it and I can't think of a better word right now. But let's take, for example, if now a physician group or a health system is on a value-based arrangement where they're closing all the gaps in care, and when they close those gaps, their HEDIS scores can go from a 3 to a 4, right? If they're pushing on that continuum and now they need lists or they need some other thing from the health plan to understand what to go for, that's a new workflow. And it's a new window that they're going to be looking at in their systems. And then now there's the whole processes of how we do it. And so helping people train and adapt to these processes, it's critical to do it without frustrating them. Like in the old days of clinical decision support with EMRs, there was this expression called alert fatigue. And so you had all these clinicians who are like, yeah, the drug interactions don't matter. And you got really quick at clicking the X window that an alert had come up. And that's initiative fatigue. It's getting in the way of how you do your stuff. But the other one that's going to be really important here is clinical documentation around value-based care. So this is another example where, as it's really important for the clinicians to be able to document things accurately and appropriately, which is critical to the reimbursement, that's cumbersome. And there's a whole new way of looking at things and coding things that health systems and providers and physician groups are training around, and understanding how providers are taking to it, how well they're learning, how well they're adapting, but also how well it fits the workflow is going to be critical to making this work. And these are the things that create, I think, a better patient experience when the patient doesn't know that all these things are happening underneath the surface. So I think value-based care is just one major, it's one of the major shifts that show the importance of focusing on employees, focusing on clinicians is critical to making sure that the total patient experience is there. My last point on this, I think, would be, if you think about the employment by hospitals and physician groups in any city, it's one of the largest employers of people. And so when you look at a large hospital system and they're one of the largest employers in a city or a town or a county, think about in aggregate all the physician groups and other clinical settings. There are a ton of people that are here to serve the patients, and making sure that their jobs are easier so they can do what they were called to do, what their mission is, so that we're getting the effort out of the way. I think that's one of the most critical aspects of patient experience.
Great. Thank you, Louis. So I want to turn it over to a few questions that have come in and just get your thoughts around some of them. The first is around diversity, equity, and inclusion initiatives. So we know that, organizations across all industries are really making this a critical focus and priority. And healthcare organizations specifically have a growing responsibility to improve DE&I, not just for their employees, but also to better serve their patients and their families. Has this topic come up in some of your work with healthcare organizations, and is it one of the top priorities that you see on the agenda for the next year and beyond?
Yeah, it has. It has. It's what's interesting is I've heard some people state it in a way that it's a priority, and in a way that felt, I heard one person state it in a way that felt like they finally came around to understanding that this is a priority. And I was almost offended by it. But you know, when you get there, you get there. And so for this organization, you know, as the person put it, it's here to stay. And I love the forward look on that. But the fact that it was a question up until it was here to stay was, you know, it's a little disconcerting. But then there's other organizations that might be more silent on it as a priority, but it's just embedded in the culture of what they do. At the end of the day, I think you nailed, you hit one of the points that I think is so important, is that it is really important for DE&I as part of making sure that all of us feel a sense of belonging, feel welcomed as we're working together. But also, if we're building patient trust, you know, patients lose trust if they don't feel respected, if they don't feel understood. And it could be, sometimes it's just a spiritual misunderstanding, but other times it gets into things like DE&I, it gets into things that are cultural. And so I think we have to think of DE&I the same way we want to understand a person's spiritual background, if that matters in how they might make decisions around, say, end of life decisions. And they will trust you if they know that you understand them, they will trust you. And I think it's a critical priority for earning that share.
Yeah, I think that's a critical point. Like it's critical to kind of deepening that patient trust, because you want to hire and retain a workforce that is ultimately representative of the patient population you serve. And so I think healthcare organizations are, you know, starting to, if they weren't already, starting to figure out how do they adopt those practices, how do they measure DE&I at their organization. And we're also seeing a lot of customers come to us for that and for that expertise. Shifting gears a little bit, I want to turn to a question around survey fatigue. So this definitely comes up a lot. How do you avoid survey fatigue if you are asking patients to complete multiple surveys? And, you know, wouldn't you expect a lower response rate if you have all these different surveys going out to patients at different times?
Yeah, I think air traffic control is probably the shortest, simplest answer. Is you need kind of a central nervous system where all of this is coming through, and someone who just says this department's not sending out in addition to this department or in addition to this organization. And so, and I'm seeing several organizations who do this well, and they want to make sure that A, that extra surveys aren't sent out, but B, they also want to ratchet down to the most important questions. And you're hearing a concept around, how do you ask 4 questions that give you the insight of what previously was 10, or how is it 2 that gets you to 4, and trying to really tighten up onto questions that really matter and are very focused drips and drabs. And if you have much more touch points, you get to ask a few questions, but to recognize the you know, the chances you have, and keep it simple.
Yep, couldn't agree more with that. So we have about a minute left. I just wanted to, first of all, thank you so much, Louis, for being my co-host today, but also just wanted to give you an opportunity. Any closing thoughts, any parting thoughts that, you know, that you wanted to touch on that you didn't get to cover?
Yeah, I'll just make 2 very, very short ones. One, the last point I made about a campaign and really understanding the questions. I probably should have mentioned that when you asked me about other ways to get beyond CAHPS, right? I mentioned NPS and how to use that strategically. So I would lump this in as the other approach, which is to build a campaign around the patient and be very selective in the questions you use. The second takeaway I would have is, I think for everybody measuring patient experience or working on feedback mechanisms like this, try to elevate the strategic conversation. Talk to your chief strategy officers, talk to your chief medical officers around what the problems are they're solving, and go beyond the questions that they think they want answered, and try to help them solve for stuff that it seems to be a problem that they haven't even articulated yet. And you don't even have to go to the CMO or the CSO. Talk to people who talk to your stakeholders who touch enough patients or touch enough processes. And just, I think there's a real opportunity to make this real strategic and evolve the questions and the campaigns and frankly, the business problems we're solving that go beyond patient experience questions directly.
Thanks so much, Louis.
Excellent.
Yeah, you're welcome.
Well, thank you, Ambika, and thank you, Louis, both for really a great discussion. We are now going to take another very short break. We will resume here at 12:30 p.m. Eastern Time for a fireside chat on the evolution of end user computing, improving the patient experience. So we will see everyone back here in just about 30 minutes at 12:30. Thank you very much.